Everyone ready to get started here? Okay, so we're starting section 3 of the class, the last section for Farm 1. It's exciting, right? Yay! And then you're done with Farm 1, and then you have Farm 2, which is twice as long, but that's okay. Well, that's all right. Any questions or anything I can kind of, so we're going to finish up section 3 today, moving to section 4 of cardio. That should be posted. Does everyone see that? I want to make sure I published it. Your farm prescription assignment is due Friday, like the 19th, I believe. So double check Canvas for the due dates and times and make sure that you get that in, because I don't want to have to deduct points for being late. That would be very unfortunate. Because you guys had so much time to do it, right? Fantastic. Heard a few expletives when I mentioned that, so hopefully everyone remember that that's still an assignment they have to do. I've also had roughly 3.5 hours of sleep as of last night due to my darling 9-month-old, so if things get a little weird, go off the rails here a little bit, please excuse me, extend some grace. Anyway, okay, so what were we talking about last time? We were talking about, anyone remember? Angina. We're actually talking about angina, right? Remember what were some good drugs that we had for control of anginal symptoms? For control of anginal symptoms, looks like a good first line drug. Remember, there's going to be a distinction between the acute treatment of angina, and then there's going to be like the meds for control of symptoms, right? To try to prevent symptoms from recurring, to try to increase exercise capacity, things like that. So what were meds that were good for that? Beta blockers are really good agents for that, right? Because again, what do they do to the heart? It's going to decrease contractility. It's going to slow it down. What does that do to O2 demand by the heart? Decreases it. Fantastic, right? Because again, remember, angina is a issue between supply and demand, as you know. What else could I have used? Could we use? Calcium channel blockers, right? And so if you could not use a beta blocker, say, due to diabetic concerns or say asthma or things like that, what kind of calcium channel blocker would you want to use as a first line agent? DHPs, non-DHPs. Remember non-DHPs, because they're going to be preferentially doing what to the heart? Slowing down the speed, slowing down decreasing contractility, right? So very similar actions to the beta blocker, just through a different mechanism, right? Now, if I had someone on a beta blocker and need to add on a second agent, and I want to use a calcium channel blocker, which would be good there? DHPs, right? Because why would I want to do that? Because they're going to be vasodilatory, right? So they're going to help with supply on the supply side of things and decreasing the afterload that the heart's having to pump again. So in that regard, it's going to be dealing with some of the O2 demand. But why would I not want to use the non-DHP with the beta blocker? Yeah, way too much slowing down of the heart. You're going to see a lot of bradycardia. You can see way too much decreased contractility, decrease in EF. So again, those would be two drugs you would not want to mix together. Good. As a third line agent, what could I add on? That's where you use a long-acting nitrate, right? That's where you get the isosorbide dinitrate or mononitrate would be good agents there. You can use things like topical nitroglycerin. Now, if I have an acute anginal attack, what can I use? Short-acting nitrates, right? So that's where you can have nitroglycerin. What route do you give that? Sublingual, right? So you either use like a sublingual spray or a tablet or something like that. What's a good counseling point for patients getting a short-acting nitrate? Yep, good. So don't take it with erectile dysfunction meds like sildenafil, right? There's actually a couple meds you could use in combination with that. We'll use an alternative, but yeah, so the big ones you think about as far as sildenafil, tadalafil, all of those for sure. What's another good counseling point? They may, but again, if you're having acute anginal symptoms, they may just go ahead and just pop a pill and just take it from there. It may not have access to blood pressure, checking. But again, what's the concern when you give someone a nitrate? You're going to drop their pressure, right? Because again, that's going to be acting both on the arterial side and on the venous side as well, right? So that's why it's good for helping to get more blood coming to the coronary vessels, but also you're going to see some hypotension associated with that. That's one concern. What's another good counseling point? Yeah, so not with the first dose necessarily, but if you don't have relief of symptoms with the first dose, then you call 911. Before we would do like every 5 minutes for like 3 doses, and then if you still were having symptoms, then you called 911. But with things with myocardial infarction, time is tissue, right? So very frequently, we'll let them have 1 dose, so that resolves their symptoms, and then they don't need to do anything else. But otherwise, yeah, they definitely need to call 911. The other big thing, keep it in the original packaging, right? And again, look at those expiration dates on those, because in general, expiration dates are kind of bogus on most drugs, but with nitroglycerin, just like we talked about how trinitroglycerin or TNT tends to break down and tends to be pretty explosive, this stuff is going to be pretty unstable too. And so if you have someone who keeps their nitro around, or maybe keeps it on the dashboard of their car in the hot Florida summer all year long, and then it's they keep it around for 2 years or something like that, it's going to break down. And so they're like, well, I didn't have any relief of symptoms, but it could be the drug's really not that much present anymore, at least in the degree that you were expecting it to be, right? Make sense? Okay. So if you have someone with angina, right, so they're already showing you they have this propensity towards myocardial ischemia, what other medications should they be on? So what are some benefits we could have with ACE inhibitors, you think? What are ACE inhibitors, what are they going to do as far as from a cardiovascular standpoint? They may help with angina. They're going to be blood pressure lowering, right? So they're going to help with the afterload aspects of things, right? So that could be good. That could be helpful in getting the pressure down under control. Heart's not having to pump as hard against that, for sure. You'll find they don't really help so much with the consumption standpoint as much as something like a beta blocker or like a non-DHP would, like verapamil or tizem. They're not going to acutely relieve symptoms of angina by any means, but why do we like ACE inhibitors so much? What do they help with long term? So blood pressure, yeah, but they also help with mortality in the long run because of the fact that they help with that remodeling that occurs, right? So again, when the heart's constantly having to pump against all this afterload, it's going to start to remodel, just like any muscle does. When you have that ischemia, this is going to cause remodeling as well. That's when the heart gets more fibrous, it's going to become more stiff, So you see all this dysfunction occur. And so by having these patients on ACE inhibitors, we find they do get long-term mortality benefits from this. And so really for anyone who has, things like LV dysfunction, diabetics, why do we like ACE inhibitors in diabetics? Kidney protection, right? Post-MI, any of these patients, they're probably going to want to be on an ACE inhibitor indefinitely, right? So it's going to be a long-term med they're going to be on there, okay? So again, that's when additional medication is not going to fix their angina, but it's going to help them live for longer due to the kind of long-term effects we're going to see with that. What else? As I mentioned, you want to consider combo therapy, adding on something else if the first drug by itself is not going to be controlling symptoms. Again, usually you'll see a lot of patients will, if they start off with a beta blocker, you can add on a dihydropyridine, as we kind of alluded to already. Could be some evidence to show that may increase their exercise tolerance. That could be good. And again, if you need a third agent on, if you're adding on something like a long-acting nitrate or something, that's where you probably want some further workup, which hopefully they're already seeing a cardiologist, but they may need to get things like angiography, things like that done to kind of see if there's any additional things they can do, like stent placements or whatever the case may be. Okay, antiplatelet drugs. Why do we like antiplatelet drugs in the case of angina? Because if we have that angina showing we're having myocardial ischemia, we're probably not delivering enough blood flow to the areas of the heart, maybe due to things like atherosclerosis. What could be something that could block up the rest of the artery, the coronary vessel? Probably some platelets, right? Again, that's why you're seeing things like, thrombus formation that can form the vessels. That usually is what's precipitating one of these heart attacks, right? So again, being on an antiplatelet agent is going to definitely be one thing you want these patients to be on anyway. And in fact, when someone's really having these acute anginal symptoms, what do you have them take? Aspirin, right? So again, we're going to look at that in a few minutes here. We're going to get into acute coronary syndromes, but absolutely they should be on aspirin every single day. What dose should they be on? 81 milligrams is fine. Right? I don't hammer a lot of doses, but that's one thing that's going to be pretty ubiquitous, and so most people know that already. Anyway, but again, 81 milligrams is going to be good. And again, why is it okay just to use such a baby dose for our adult patients? It's an irreversible inhibitor of those platelets, right? So as long as you're producing new platelets, you're going to have that little bit of aspirin around that can interact with them, inhibit them, and hopefully prevent that aggregation of the platelets occurring there. Okay. Now, if some patients do not tolerate aspirin, they cannot be on aspirin for whatever reason. That's where you can see something like clopidogrel or another one of those ADP receptor antagonists can be useful there. So something like ticagrelor, prasugrel, I mean, those are going to be fine. Just remember that obviously, what are the big side effects with antiplatelet drugs? Bleeding and bruising are the biggest things you're going to expect to see with those. So again, just be mindful of that. Okay, so again, unless they have some kind of contraindication, these patients with angina should be on aspirin. They should be on a beta blocker if they've had a previous MI. We'll go into more detail on that in just a few minutes here. Certainly, the diabetes or LV dysfunction, they need to be on an ACE inhibitor for sure from that standpoint. Typically, you want them on lipid-lowering therapy as well, usually with what? Statin, rosuvastatin is a good one. What else could we use? Atorvastatin, those are kind of the two big ones. Simvastatin, a high dose, could also be used as well. Again, not just due to the fact we're getting the LDLs down, but also due to all the other ancillary effects from statins we know about, right? And then they should also have a prescription for sublingual nitroglycerin, right? And so how do you think that prescription would differ as far as directions go versus the other agents? Yeah, it's on an as-needed basis, right? So as opposed to like something like your aspirin, not that you write a prescription for aspirin necessarily, but your beta blockers, ACE inhibitors, those would all be scheduled. Say take once a daily, twice daily, no duration. Certainly the sublingual nitro is going to be on an as-needed sort of basis there, right? So again, that's the rescue medication. When we get to Pulm and talk about asthma, you'll see that similar delineation between your rescue medications and your controller medications. So it's important to keep those distinctions in mind on how your directions are going to change as well, okay? And then again, if they're having daily, more frequent symptoms, that's where you can add on some of these controller meds, things like beta blockers, calcium channel blockers, and a long-acting nitrate, right? Usually, generally in that order for the most part. Now, what happens? You remember we talked about that prinzmetal angina or that variant angina? It's kind of this usually going to be in younger patients. Usually, they don't have any real history of cardiovascular disease. This is going to be when they have that kind of vasospasm that occurs. They can include blood flow going to the heart there. This is typically where you're going to find that our dihydropyridine calcium channel blockers are going to be better suited to treat this. Okay, and again, that makes sense because if our main issue is vasospasm, it's not necessarily the heart is demanding too much oxygen. It's more of an issue of supply there. So if you can give a drug like a calcium channel blocker, namely like an amlodipine or nifedipine, anything like that, it's going to help to relax some of that smooth muscle and allow for that vasospasm to hopefully be blunted and prevent the anginal symptoms to occur there. Okay. And actually, in these cases with beta blockers, it may lead to worsened symptoms because you may have this case here where you're actually decreasing cardiac output, but you still have that vasospasm occurring, and you're not really treating the main issue there. So in those cases, a calcium channel blocker is preferred. You could also use maybe a long-acting nitrate as well, because again, we know that's going to cause smooth muscle relaxation, right? All right. Let's talk about acute coronary syndromes. So what's our main delineations of acute coronary syndromes? STEMIs and non-STEMIs right on the slide. This beautiful new projector we have here. You can see very well. Different screens all around the place. Yeah, so the main thing you're going to find is you're going to have these ST segment elevation MIs, or STEMIs. You're going to have the non-STEMIs. Typically, non-ST elevated acute coronary syndromes can be delineated into things like unstable angina. And when I say unstable angina, what does that mean? Yeah, symptoms at rest, right? So again, if I have stable angina, it means I can get around, I can walk around before I have symptoms occur. In this case, unstable, it just means at rest I'm having symptoms happening there, right? And then you can develop into a non-ST elevation MI. And again, I'm not going to get into how you diagnose that on EKG. That's for your other classes. Again, I'm not on the diagnosis standpoint. But the treatment, certainly we will get into, because a lot of this is going to be medical management. And actually, we'll see how that's kind of changed as time has gone on here. But again, a lot of it goes down to, what degree of blockage have we had here, the coronary vessels, what degree of ischemia are we actually seeing here occur. So again, what's happening when you have these vessels becoming occluded, leading to this myocardial ischemia? And again, I'm not going to go, super deep into the pathophysiology, but I'll kind of point out the key points where our drugs are going to be interacting here. But typically, imagine if you had nice endothelium here. You have this fibrous cap. This is a nice stable plaque here, right? Certainly it's occluding some flow of blood here, but it's not going to be something that's going to be potentially causing death anytime soon, right? Or any kind of serious harm here. But what do those plaques stay stable forever? Now, hopefully like a statin on board or something like that is going to help to keep them stable for longer, but you could either have a spontaneous rupture, or you could have something like if you had, say, a balloon placement, if you were going under, PCI or something like that, that could also rupture the plaque and allow for kind of release of some of these kind of prothrombotic sort of material here, right? That can then start to lead to platelet activation, aggregations. As you start to see this start to bind up, what else kind of gets involved in that plug there? So platelets, and the other big thing is it's kind of the web that holds it all together. Fibrin, right? So again, fibrin is going to be a big thing here because fibrin is going to be a big target for where our drugs are going to be focusing on in just a few minutes, as we'll see. Okay. Yeah, all that fibrin strands start to form. What do you notice about the flow through this vessel? It's starting to get a little crowded there, right? It's going to be hard for blood to flow, and that's when you start to see that, decreased delivery of oxygen-rich blood to the heart, and that's where you see the ischemia occur. And then this is where you get a very occlusive sort of thrombus here. Main things to note when you have this thrombus formation, we're going to see that some of our drug targets are going to be playing a role here. So for instance, going back to your hematology lecture from section 2, right? Hopefully everyone's still holding on to your information about heparins and antiplatelet drugs and all sorts of things, right? I'm going to assume yes. I see a couple of heads shaking. Up and down, so I'm going to assume that's yes. Right, so again, we have things like collagen being exposed in these vessels here. This is where things like ADP, which kind of drugs affect ADP? Clopidogrel, prasugrel, yeah, ticagrelor, those are all good ones there. What would affect thromboxane A2, do you think? Aspirin would be affecting that, right? Because that's part of that arachidonic acid pathway. It's where cyclooxygenase would be interacting with that. So again, already we can see where aspirin and things like ADP blockers are going to be useful for helping to block this platelet activation occurring here, right? Again, the aggregation occurs, and that's what's going to start kind of forming up that thrombus that occurs there. Now, on the other hand, you're going to see that we have things like tissue factor being exposed, and this is where we're going to have the clotting cascade playing a role here. So what kind of drugs would I want to use to help affect that clotting cascade? Your heparins are going to be playing a role here, right? So your heparins, your low molecular weight heparins like enoxaparin, drugs like that are going to be very important here because they're going to start to interrupt that clotting cascade, right? Now, would warfarin be a good option right now? No, because what is warfarin going to do for us? Prevents production of new clotting factors. It doesn't do anything for those actively circulating factors that are actually leading to this thrombus or kind of propagating it. So because of that, something like warfarin has no role in the kind of the acute phase here. However, you could use something like, and actually what we're starting to see nowadays is that there's some protocols where if you have something like a DVT forming, right, where you could actually use something like the newer oral anticoagulant drugs. When I say that NOAC, what is that? What drugs am I referring to? Dabigatran, rivaroxaban, apixaban, those oral agents, and actually some patients are just being put on oral agents right from the get-go, from diagnosis in the ER, and sent home on that, right? But again, we're talking about acute coronary syndrome here, so you'll see the therapy differs a little bit. Heparins, low molecular heparins, are going to be playing a big role to interrupt that clotting cascade. The other big benefit with using some of these agents, especially with like heparin, is you can titrate it, right? Because again, it's via continuous infusion. If you're getting too anticoagulated, you dial back the dose. If they're not anticoagulated enough, you're going to increase the dose. How do you monitor for heparin effects? APTT, right? How would I monitor for something like enoxaparin? Anti-factor 10A, right? Because again, remember enoxaparin, as you get that shorter heparin sort of molecule, that chain gets shorter. What does that have preference for? Which factor? 10 rather than 2, right? Heparin's kind of equal between 10 and 2, but as you get shorter, you're going to find more 10 activities going on there, right? How would I monitor for a warfarin if a patient was on that? PTINR, right? So remember your monitoring parameters here. Actually, in one of the newer things you may find going forward is that because heparin does have effects on factor 10, in some places they're actually going to be monitoring heparin effects with anti-factor 10A. So if you see that going forward, that could be something that is done. It may be done more frequently as time goes on. Those labs tend to be a little bit more expensive than an APTT is. It just depends on where you're working out, kind of what their protocols are. But that's something you may see. I didn't want to tell you that before during the heme section because that would just confuse you, but just know that you could use anti-factor 10A to monitor for heparin activity. We're starting to see where some targets we're going to be focusing on. Now notice here factor 10 and 2 are going to be kind of along that common pathway, are going to be big roles to play. And in fact, when we have thrombin form, what does thrombin kind of catalyze the formation of? Fibrinogen over into fibrin, right? So this is going to be a big role to play here. So again, we're going to focus on drugs that are going to be preventing sort of the activation of factors like 10 and 2 and forming that fibrin. We're also going to find drugs that are actually going to be working directly on the fibrin to break it down, right? So again, kind of focusing on the production side and also on the actual the metabolism side as well. Again, this is all going to be this positive feedback loop because not only can things like thrombin affect the clotting cascade and feedback and further elicit more responses there, but you also find that affects the platelets as well. So you can see how this gets out of hand very quickly, and you can have that total occlusion of that vessel there, right? So, and again, thrombin, fibrinogen converting this over to fibrin, this is where we're going to see that final kind of stabilization of that plug there, and this is where we're going to be focusing on when you need to get rid of a clot quickly, this is where we're going to try to get rid of it, by getting rid of this fibrin. So I'll show you some options on what we can do for that a little bit later. Okay, so our goals here, we'd like to reestablish coronary blood flow, right? Obviously, we're going to look at some options we have to treat things like chest pain. We'd hopefully, like, if you catch it early enough, hopefully prevent progression to MI, which is again why when you have patients on a short-acting nitrate like that, that's why we're telling them if the first dose doesn't, resolve your issues, call 911 then. Before, if you're waiting an extra 10-15 minutes. That means that tissue is just sitting there kind of mounting that thrombus is propagating, time is tissue. So that's why we make that recommendation nowadays. And then after the MI or whatever damage has occurred, hopefully prevent, the development of things like heart failure, because we know there's a lot of remodeling that occurs after that ischemia happens there, and then hopefully prevent death, right? That's generally our goal for most days of the week, I would think, prevent death. Anyway, so you're going to find that there's kind of common pharmacologic agents you're going to use between the two, both STEMI and non-STEMI. We're going to see there's a few cases where the therapy is going to differ a little bit here. So typically aspirin, you want to use it the first signs of chest pain. Basically what we'll have the patients do is they will take 4 81 milligram baby aspirins if they have access to that, or they can just take a normal 325 and they'll then chew that up. And what does that chewing do for us? Yeah, it kind of aids with the absorption. Instead of having that tablets have to like dissolve in the stomach, it allows it to kind of break up a little bit sooner. Hopefully has a little bit faster absorption there. It doesn't taste very good, but it is one of those things that could make a difference for your patient, right, from a mortality standpoint. So have them chew it up, and then we know that reduces mortality and also reinfarction down the road. Yes, sir.
If somebody takes an aspirin, like a baby aspirin every morning, and they have chest pain later in the day, they've already taken 81 milligrams, would you want them to take 3 baby aspirin?
I would see how long it's been. Honestly, like when you're in the heat of the moment and someone having like an acute episode of chest pain, like you just go ahead and just give them the 4 anyway, right? So for instance, we run into this most frequently. The time we don't deal with a lot of adult patients at Nemours, but the times we do is when you have like grandma visiting, grandpa visiting up on the floors, and they have what we call code triage, or basically is where like an adult patient or something goes down, or they start to have chest pain and things like that. We'll roll them down to the ER, get them stabilized, and then send them out to an adult facility. But again, it's one of those things where like, yeah, they could be on 81 milligrams every single day, but we still probably just give them the 325. Again, that's just what most of the protocols say. I don't know if there's just, would it really truly make a difference if you did 3 versus 4 tablets? Probably not, but it's just what we normally do. Anyway, also, then we're going to be looking at our nitrates. Now, nitrates are mainly going to be treating what aspect of this? Yeah, it's going to help with some vasodilation. So again, if you have someone who's like really hypertensive, nitrate is going to help with this. But this is more kind of a short-acting nitrate we're looking at. But mainly, we're using this for chest pain, right? So again, when you're in pain, what also is occurring there? What kind of gets activated when you're in a lot of pain? Sympathetic nervous system that releases a lot of things like norepi. What does that do to your blood pressure? It's going to increase it, right? What does it do to your heart rate? Increases it, right? You're increasing myocardial oxygen demand. That's not what we want to do. So if we can give them things to help with the chest pain, that's going to help to kind of calm them down a little bit, get them chilled out. Because again, if someone thinking, oh my gosh, I'm having a heart attack, they're probably freaking out a little bit. And so you need things to kind of chill them out a little bit. The nitrates can help with that by eliminating the pain aspects of it, okay? So again, most patients will end up getting nitrates because again, chest pain tends to be one of the precipitating causes for this. Also, you're going to find that a lot of patients end up receiving beta blockers. Now, obviously, depending on how your patient presents, if they come in, they're already bradycardic because of the damage being done to the heart, do you want to give them a beta blocker? Probably not, right? But if it's one of those things where they're tachycardic, they're hypertensive, a beta blocker can be a really good option for those patients there. So you typically want to get them started on it sooner rather than later. But again, take the clinical picture into mind. If they're already coming in, they're already bradycardic, don't give them a beta blocker at that point, right? But we do know this helps with decreasing mortality in those MI patients. That's why we prefer that. As I mentioned with aspirin, the only contraindications we're going to have here are going to be things like they have a documented allergy for this, they've had like maybe a recent GI bleed, or any kind of intracranial hemorrhage, any kind of like really bleeding episode here. You're going to find that would be contraindicated. Now, are there going to be other options we can try using here? Possibly, but we're going to find that it's going to be one of those cases where if they have like recent history of hemorrhagic stroke, I probably would just go ahead and avoid it at that point, just because they are at that much higher risk. But we do know it helps to decrease that recurrent ischemia, reinfarction, etc. This is going to be definitely a gold standard here. What's the acronym used for meds you give to a patient with chest pain? MONA, which, and again, what's the A stand for in that? Aspirin, right? Good. Next, we have the nitrates. We mentioned that's going to be good for sublingual therapy. The spray, the tablets, anything like that can work. But again, what are the main side effects you see with nitrates? Hypotension is going to be the big thing, right? So again, you can see hypotension. If their patient is already in cardiogenic shock and they're already hypotensive, nitrates may not be the best option for that patient, right? What else? Which other patients would I not want to give nitrates to? If they're on one of those erectile dysfunction meds, like I mentioned, right? What could potentially precipitate an MI? Physical activity, right? So again, take the patient's history into account. And what was the thing that led up to that acute chest pain? Maybe it's one of those things where, hey, wait a second, like you're having a good time, you're out dancing on the weekend, like you're out with your significant other. Are you taking any of those medications? Because again, patients may not want to be forthright with that stuff, but you need to ask some questions, get a good history, because then that may preclude you from using things like nitrates. Because if I use this along with one of those phosphodiesterase inhibitors for erectile dysfunction, what do I see? Profound hypotension can be very difficult to treat, right? And again, if I'm underperfusing the heart, that's just going to worsen my ischemia. It's no good, right? Anyway, again, there's no actual mortality benefits we've seen with this. It just helps with the chest pain, helps it relieve that, and that can help to kind of calm down the patient kind of overall if you eliminate that pain there. I mentioned beta blockers typically start with IV, and then you can follow up with PO. Again, be careful if they already have heart block, they're hypotensive, bradycardia, just avoid it in those cases there. Now, looking at my agents here, if I had someone who is a severe asthmatic, which ones would I want to use? Beta 1 selective, what are some options there? Atenolol, metoprolol. Yeah. So Carvedil is one of those third generation agents. Would not be wrong in this case there, but not specifically a cardio 1 selective. I will tell you, as far as IV agents go, IV beta blockers you're most likely going to be using here could be including things like metoprolol. There's also another really good one called esmolol, right? Esmolol is in the A through M, so you know it's a cardio selective beta blocker there, beta 1 selective. And that one's really good because it's given by a continuous infusion. It's another one of those things where I can titrate the dose to see how they're doing as far as like blood pressure, heart rate goes, and so that could be a really good option when you're in the ER sort of setting there. But again, we see mortality benefits, which is why we like beta blockers for these patients. Helps with things like heart failure incidents, etc. So we definitely like having beta blockers on these patients. And then what was the M in Mona? Morphine, right? So again, why do we give morphine? For pain, right? It's specifically for the pain. If my patient is well controlled with just nitrates alone, do I need to give them morphine? Not necessarily, unless you're just feeling really generous that day, right? You don't necessarily need to do that. So it's one of those things. And again, is there anything magical about morphine? Could I use other opioids? Absolutely, right? So again, if I had someone who had a morphine allergy, we have lots of other options that are there. We'll talk about those later on, and probably in Pharm 2 when we get to talking about pain management. But if you have like fentanyl or Dilaudid or anything like that, any of those options are going to be good here. It's just traditionally morphine's been used. It's been around forever. It's what we've used most frequently, right? So again, if the pain is unresponsive to the nitrates, then you can utilize something like morphine, 1 or 2 doses or so, to try to get that pain under control. And again, you constantly want to do that reassessment. You see what their pain scales are looking like, to go back and see, okay, well, how effective are these drugs being? You know, do the nitrates, how well is that affecting them versus how the morphine is going to be affecting them? Just kind of keep that in mind. Now, again, who do you have to be careful with giving morphine to? Obviously, they have a history of morphine allergy. You want to avoid this. The other thing to think about is that we talked about codeine before. Remember we talked about that CYP2D6 polymorphism where like patients may not be able to convert codeine over into morphine, or someone can do it too rapidly. So that would stand to reason if someone has a codeine allergy. Do you think they also have a morphine allergy? Does one drug get turned to the other? It would stand to reason that yes, you would have a cross-reactivity there. So if you see codeine allergy, morphine allergy, this is something you want to avoid morphine for. Okay, so the allergy is one thing to consider. Another kind of unique thing about morphine itself is it actually stimulates histamine release. So histamine release, what do you think that may cause? Like itching. What else does histamine do to the blood vessels? Causes dilation, right? Because remember, think about the typical allergic reaction where you're having like blood vessels dilating, you're getting all that edema, you're getting that itchiness. A lot of that same thing is happening here with histamine. So some people don't tolerate morphine very well because they have a lot of that histamine release, and so it's not a good agent for them. But by having all that histamine being released, you could see more hypotension, right? So again, be careful. If the patient's already hypotensive, this could worsen that potentially, okay? All right. So those are kind of the main drugs. Again, I'm not going to get too much into the oxygen standpoint because, again, that's going to be more managed by things like your respiratory techs and things like that. But again, make sure you don't give them too much oxygen. You know, anything can be a poison in a big enough dose, and that stands to reason the oxygen can also be a poison as well. It can be pro-inflammatory, so just be careful with that. Anyway, getting into looking at the agents we're going to use to deal with the clotting cascade here. So what agents do you think we're going to use to interrupt this? So I mentioned, am I going to use warfarin for an acute coronary syndrome? No, right? Because again, it doesn't do anything to the already activated clotting factors out there. What else might I use? Heparin, right? Heparin's good because that's going to help us to make antithrombin 3 work better. It's going to help us to eliminate things like factors 10 and 2, but also 9, 11, 12. If you guys go back and review that stuff, there'll be important information there. Heparin's going to be used here. Low molecular weight heparins like enoxaparin are going to be good here. Direct thrombin inhibitors could also be potentially used here, right? So you have several agents. You want to go back and kind of review those. They're going to help to interrupt this pathway here, okay? We're also going to see that one important thing we're going to see in just a few minutes here is also going to be this pathway here, and this is actually how we're going to get rid of our fibrin. So basically, has anyone ever heard of TPA before? What does that stand for? tissue plasminogen activator, right? So this is what actually converts plasminogen over to plasmin, and then plasmin breaks down fibrin into those fibrin products, and that will help to bust that clot. When you hear about a clot buster, that's what we're talking about, are things that are activating that conversion from plasminogen over to plasmin. TPA is going to be the most common thing you're going to see used here. We'll talk about that a little bit later. But again, remember, we can either use things that are going to help to stop the already working factors here to producing, they're trying to produce a new fibrin, and we can also have things that are actually going to help increase the breakdown of that fibrin as well. And oftentimes you're going to be attacking it from both sides there. But again, what do you think are going to be the big side effects from both working on both sides like that? Bleeding, right? Bleeding is always going to be the major side effect. Anytime you're monkeying with the system here, bleeding is always the big risk, okay? All right, so this is where we're talking about our fibrinolytics. We'll kind of touch briefly on things like the heparins in a little bit when you're going to use those, but now we're going to talk about the fibrinolytics. Fibrinolytic just means breaking down fibrin, right? So again, it's going to be the things that are going to help us to basically break that down. Is where TPA is going to be playing a role here, right? And again, this is going to help us to activate the already circulating plasminogen that we have floating around already, right? And again, we're going to find TPA is going to be the big role to play here, but it also helps to break down some other products as well, things like factor 2, 7, and 5. So again, there's some additional benefits to getting that plasmin working for us. So a couple of different agents we have that could work through this. You know, you can have certain things like something like Streptokinase can actually form a complex with plasminogen, and this is what actually helps to expose like a catalytic site. And by doing that, it'll help to convert that plasminogen over to plasma. It just makes it more ready to make that crossover. Or you get things like direct tissue plasminogen activators, which are actually going to bind to that fibrin that's bound and converts it over to plasmin and then lyses that clot. Right. So again, this is why you see TPA being used pretty frequently here. Again, just know there's the problem. And here, if you're looking at things like streptokinase or plasminogen, can all be working here to convert that over from plasminogen over to plasmin. Right. Urokinase is another one you won't see too often, but this is where TPA kind of helps with that direct conversion over. Because this is kind of a direct one-to-one kind of action here, this is why we like TPA very frequently. So that's the one I'll probably be focusing on most likely here. So anyway, things like streptokinase, urokinase, we don't see those used in the US too much. They were kind of having some issues because they work on both circulating and fibrin-bound plasminogen. Now, if we wanted to be more specific, we'd like to target those clots that are actually formed there. And so this is why we actually like things like TPA. A couple other agents you may see used out there include things like redoplase and then tenecteplase. Those are actually going to be working only on fibrin that's actually bound, or a plasminogen bound to that fibrin. That means it's going to be a little bit more specific and not working on fibrin all throughout the body, but we're working on those clots. And again, that's going to help us reduce that risk of having these kind of life-threatening bleeding reactions here. Okay. Now, again, can you kill someone with heparin by giving them too much? Yeah, but we have things like reversal agents. It's not going to be like an immediate sort of thing here. Can you kill someone with TPA? Absolutely. Like, this is a very dangerous drug you're going to be administering to these patients, and so it's very, very important that you be very judicious about who's actually going to be getting this. Okay, so just know this is a very dangerous drug, and so you need to be have a healthy respect for it because of the negative outcomes that can come about from it. Anyway, as I mentioned, bleeding is going to be the biggest risk with any of these. So again, does that mean bleeding around the heart? Could be. It could mean bleeding in the head, could mean bleeding all over, GI tract, anywhere, right? Bleeding can occur because when we're giving this drug, we're giving it systemically, which means it can work systemically. Now, is there a way to better target it? Actually, there are. There's some cases where we can actually do direct catheterizations right to the clot and actually inject smaller doses right to where the clot is to help break that up. That's something like if you work with like interventional radiology or with like a cath lab, they can do those sorts of things, and that can be very nice because it helps to limit the kind of the body burden the patient will be exposed to in those cases there. But anyway, other big things you're going to find is that allergic reactions are going to be big here because these are protein-based products we're administering. It also means they're probably going to be very expensive as well. And so again, you're going to be finding that you can have certainly some manifestations like fevers, chills, etc. But anaphylactic reactions should certainly be on your radar as well there. Okay. Then also you can see some ventricular arrhythmias. Now, what can occur when you have an MI? Ventricular arrhythmias, right? Anytime you're causing ischemia to the heart and you're causing damage to those cells, that can also lead to arrhythmias. So sometimes it's hard to say, well, was it the arrhythmia caused by the MI or was it caused by the drug? It's sometimes hard to tell, but we think there is some association there. You can see some arrhythmias, so just be aware of that. Now, here's some listed contraindications. These are things you have to screen for before you give any kind of plasminogen activator, because again, as I mentioned, these are patients that are most likely to have a really bad outcome if you were to administer this. If they meet any of these contraindications, you do not give the drug. Okay. And again, we'll give these drugs as well for other things like if we have like a really serious PE, or if we have like things like an ischemic stroke. There are other cases where you have these kind of embolic events where you're going to be giving TPA. These contraindications will be typically pretty well standard for those as well. It may see a little bit of difference, but in general, these are the things you're looking for. So big things to look for. If you've had any kind of recent damage done to the vessel, if you had surgery done, if you've had any kind of like head or facial trauma, why do you think this would be a contraindication? Your risk for bleeding is going to be higher, right? And very serious bleeding can occur here. So that's why you'd be why you want to contraindicate it from that. Serious gastrointestinal bleeding within the past 3 months, right? So now you have to think about, okay, go back to the history. Have they, anything within the past 3 months, have they had any issues with GI bleed that would contraindicate them from receiving this, right? History of hypertension. And again, this goes back to looking at specific things like diastolic pressure greater than 110. Is that high? Yeah, diastolic pressure greater than 110, that's high, right? And so this is one of those cases where you can actually give treatment to that. You can try to get that pressure down under control. And what are some agents I could give to a patient who's in the ER having acute coronary syndrome that could try to get their blood pressure under control? Say that again?
Clonidine.
Yeah, clonidine could be an agent. You could try using clonidine, right? That could be one way. What else? You have a whole litany of options, right? You have things like beta blockers, you have things like calcium channel blockers, you have things like nitroglycerin, right? We can actually give them that IV nitroglycerin. Maybe we'll switch them over once they get into the ER and actually give them IV nitroglycerin to get the blood pressure under control. There's ACE inhibitors we can use IV. You can use things like enalapril. They have all kinds of options you can try to get their blood pressure under control. Hydralazine. You can go back to your hypertension lectures and look at all those different drugs we have. A lot of them are available. We can use in the IV form very quickly to try to get that pressure under control. If you can get it under control, sometimes they can still give the TPA, but oftentimes that will be a contraindication there. Any active bleeding or hemorrhagic disorder, that should be pretty clear there. Previous history of a CVA, so that any kind of like previous history of stroke, if they have any kind of intracranial process, so this is more specific like patients with brain tumors and things like that. Aortic dissection, obviously, bleeding risk is big there. Acute pericarditis, pregnancy. In pregnant patients, developing an MI is rare, but could be a potential thing to watch out for. And then any kind of previous exposure to these drugs where they've had an allergic reaction. And again, anytime I give these foreign proteins, I may not have a reaction the first time, but could the chance increase the second time? Absolutely, because I can sensitize that immune system for the second round go around. Okay. So the big agents we're going to see used here include things like alteplase, reteplase, and tenecteplase. These are the most common ones. The one that I use most frequently is going to be alteplase. And again, work over at the peds hospitals, not that we see a lot of MIs coming through there. Sometimes we'll have adult patients who develop an MI, but we're usually not going to give TPA there for that case. The big place you're going to see a lot of TPA being used here is actually for catheter occlusion, right? So if I have an IV placed, say either like a central line or peripheral line that's been there for a while, there is always a risk that some blood's going to get in there and it's going to clot off, okay? Now I can do things like I can leave things like heparin in the line, and that will help to prevent clots from forming there. But in some cases, even the best laid plans of mice and PAs lead to those vessels, those catheters being occluded, right? And so this is where TPA can actually be used. We use smaller doses and actually instill that into the line, and that will help to break down that clot. And then hopefully we can get a nice flushing line again, and we can use that for med administration or labs or whatever the case may be. So very frequently you're going to see TPA. If you ever see the brain in cath flow, that's what they're talking about, is that catheter flow to try to break up that occlusion there. Okay, but again, when we're talking about for acute coronary syndromes or ischemic strokes or massive PEs, this is where we're going to be giving like the big systemic doses of TPA here. Okay. Again, I always like to note if there's kind of funny places these drugs come from. Chinese hamster ovary cells. Again, the scientists who figured that out, good for you, I guess, but question your hobbies. Very expensive though, right? So again, you not only want to be judicious because of the fact that you could potentially kill a patient with this drug due to the bleeding complications here, but it's also pretty expensive as well. So you got to be watchful for that. And again, looking at this, you can find that, based on the source, you may find that one patient may be allergic to one variety, but not have a cross-reactivity with another one. So for instance, here with reteplase, form an E. coli cells. You may have a patient who's really had a hypersensitivity to reteplase, but has no problem getting alteplase. So there's not really a good cross-reactivity between these. If you had an issue with one, you could potentially receive another one, okay? One of the benefits of tenecteplase here is that it actually has an increased half-life over TPA. If you look at a TPA, here, this alteplase, this is actually just the form that we produce already. It's actually the same amino acid sequence. With tenecteplase, it actually kind of changed around some of the amino acids and increased the half-life, and so there could be some benefit to that. There's an increased affinity for fibrin, so in some cases you may see that being used over alteplase. Okay, so it just depends on who the providers are and what they prefer. And again, usually what you're going to find with a lot of these is that time is going to be of the essence here. You're going to find the longer the patient is dealing with these issues, these ischemic issues, the less likely these drugs are going to be all that effective here. And so our indications are going to be in patients less than 75. If they're over 75, why do you think they would be a bad candidate for these drugs? They're more likely to bleed, right? So again, you need to be really careful. These elderly patients are more likely to bleed. Would not be great there. Again, within 12 hours, if they're past that, they've been dealing with this pain for 18 hours or so. This drug is not going to be recommended for them. Only again, the risk versus benefits is going to find that you're weighing more on the risk side than on the benefit side there. Okay. And then again, very few patients are getting these from a systemic standpoint. A lot of times we're going to be using like direct catheter guided thrombolysis, right? Thrombolysis means we're just lysing that thrombus there. So you may see that used with like interventional radiology or in your cath labs, as the case may be. But just be careful. Anytime you're giving these drugs systemically, bleeding is the biggest risk. Intracranial hemorrhage, huge risk of this. You can definitely kill a patient with these drugs if you don't follow those contraindications. Okay. Okay. Other things you may see being used. So again, things like glycoprotein 2B3A inhibitors. Anyone remember any agents fall into that category? Abciximab's a good one. Eptifibatide. Tyrofibin, yeah, those are the three big ones there. Now, normally those are going to be used more, and again, this is more talking about specifically STEMI. We'll talk about their use a little bit in a few minutes with non-STEMI here. But don't see these used too frequently. Very frequently, though, we will give ADP receptor blockers. So we'll give things like prasugrel or ticagrelor. We'll give those as like a big bolus up front to try to use as a loading dose, get them up to steady state, and that helps with clot prophylaxis in case of things like stent placement. And again, anytime you put a stent in place, you're going to find that can be a good spot for things like platelets don't want to adhere to. So that's why we're going to give antiplatelet drugs on top of that. Okay. And then often we're going to be giving heparins in conjunction with either antiplatelet agents, or if we're using fibrinolysis with something like alteplase, we're going to be using heparins along with that in order to make sure that those extra clotting factors floating around are not going to be causing any kind of worsening of that thrombus. Again, just kind of show you when you get a stent placed here, you can kind of see how there's a couple of varieties. You have things like bare metal stents, and there's also what we call drug-eluting stents. They have different recommendations as far as like how you anticoagulate those patients or what antiplatelet agents are going to be on. But you can imagine here just having that metal there is going to be kind of a foreign material that platelets like to adhere to. And so that's why we give those antiplatelet drugs, why they're so important there. Because again, if you were to have a rethrombosis due to maybe missing your medications or something, that can be very bad. You have to go back in and restent them, and it's no good. Okay. For non-STEMI, you're going to find that treatment is very similar here. You're typically going to find no fibrinolytics are going to be used for non-STEMIs. Typically, the risks are just going to be far outside of what the benefits may be there. And in these cases here, you're actually going to be using more low molecular weight heparins. So like enoxaparin is probably going to be your go-to with that one. And then you see more glycoprotein 2B3 inhibitors used more commonly, especially like in regards to like going to the cath lab and whatnot. Okay. So any questions on ACS? So again, kind of fibrinolytics are the big new drugs that we saw there. You can be very careful with those. I was scared as a pharmacist handing that drug over after you mix it because you're like, ooh, please don't bleed out, please don't bleed out, because you don't want that kind of egg on your face afterwards. It's no good. Anyway, all right, so let's do a 10-minute break now. We'll come back and start working on heart failure. Okay. Anywho, so moving into heart, are there any questions from the first half there as far as therapy for acute coronary syndrome? Remember, your MONA is really important up front. What's your morphine if pain is not relieved by nitroglycerin, oxygen, nitroglycerin, aspirin, get that on board. Again, beta blockers are good in the meantime, but remember those contraindications. So if I had a question on a test, said, you had a 64-year-old dude coming through, rolling into your ER, his heart rate is, 54 and blood pressure is, 80 over 40, what is the next best med to start at this point? And if I said nitroglycerin, you would say, nah, because his blood pressure is too low. We wouldn't want to do that. I would say, no. I said, no, thank you, sir. Again, 3.5 hours of sleep, so bear with me here. Yeah, so that may not be the case there. How about a beta blocker? Probably not a good option in that case there, right? Because again, it's going to just lower the heart rate, lower the blood pressure, not a good option in those cases, all right? So again, little things like that. You want to think about the patient case, think about the vitals, think about how the drugs are going to be affecting that very specifically there, okay? All right, moving into CHF. Again, this is kind of a good segue because a lot of times you're going to find that a lot of patients who develop an MI or acute coronary syndrome will develop into heart failure, as you'll see. A lot of cases there. Now, there are lots of other cases. You can have things like alcoholic cardiomyopathies that can lead to CHF. You know, you can have a really bad breakup, and you get a broken heart that way. Just kidding. It all could be like drug-induced cardiomyopathy. So there's a couple cases here. Yes, sir.
What was the answer to that question? What would you give them?
I don't know. It would depend on, I guess, what was. I guess I didn't really set up a good like next drug to give at that point. I don't know. So I'm just trying to look at things that would be contraindicated, right? So for instance, you know, if you hadn't had aspirin yet, give them aspirin. You know.
Okay.
Yeah. So again, look for things that are contraindicated. If the patient hadn't received aspirin, like there's no obvious contraindications, give aspirin, right? Things like that. Does anyone know which heavy metal actually causes cardiomyopathies? Actually, cobalt. Cobalt can do this, and you may think, well, why in the heck would I ever need to know that, Dr. Wood? Like, that seems silly. Actually, it does come up. It's important because there was a big controversy several years ago where a lot of the hip replacements and knee replacements that we had there were metal-on-metal joint replacements. And so one of the metals they used in that was actually cobalt. And so, again, when you imagine metal and metal rubbing against each other, what happens? Some of that metal leaches off, right? And so just due to natural abrasion, you're going to see some of that metal leach off. And so you had new cases of CHF developing, and they couldn't really figure out why. A patient may not have a whole lot of like risk factors for it. And they're like, oh, you know, let's look at the, you know, looked at metal levels, they looked at cobalt levels, and actually find they were high, right? So again, sometimes even things that you may think, you know, could be completely innocuous can actually lead to some of these kind of more severe outcomes as you go along. So just something to think about. Yeah, other drugs can cause this as well. Is anyone familiar with the drug Ipecac? What is that? Makes you throw up, right? If you've ever seen the Family Guy episode where they'll drink Ipecac, yeah, that's what it was. It's an emetic drug. We used to use that very frequently. We'd recommend it for poisonings. Nowadays we don't do that anymore because we realize it really wasn't that effective. But the other thing is that who might abuse that drug? Yeah, bulimic patients, right? So they're abusing it for weight loss, and what they found is you had these like young, adolescents who were abusing this stuff, and they actually found that one of the components of Ipecac actually causes like this. It was a known cardiotoxin, causes really nasty cardiomyopathy. So you had these young patients come in who were very thin, but they'd had this like massive heart, and you're like, what the heck's going on here? And you go back and figure out it was actually the Ipecac. So that's the reason why you don't see that anymore. You may see like some homeopathic versions out there, but you actually can't get Ipecac out there at all. I actually have a bottle, I think, in my office that expired sometime in the 80s or something. So again, it's been off the market for quite some time. I would not recommend taking it, or really anything in my office for that matter. It's a lot of really old stuff in there. Anyway, my lunch from yesterday. I'm just kidding. Anyway, so a lot of the issues here, we're going to find that the drug therapy we're going to be using is going to target either kind of the symptoms of heart failure, try to help increase, things like exercise tolerance and whatnot before symptomatology occurs, or we're going to be trying to arrest the progression of disease, right? And again, is there any way to fix a patient with CHF? Can you kind of get them back to a normal working heart again? No, you can't reverse the damage unless you transplant a new heart into them, but you can try to stave off further progression. So that's what we're going to be targeting with a lot of these therapies here, as we're going to see, right? Anyway, so again, one of the big things you're going to be shooting for, especially with like this systolic dysfunction, you're obviously going to be evidenced by things like, reduced ejection fraction. Now, because of that, what kind of drugs would you want to avoid potentially in a patient with systolic dysfunction? What could worsen my EF? Beta blockers, non-dihydropyridine calcium channel blockers. But again, you're going to think back and like, wait a second, wasn't beta blockers one of the drugs I used for CHF? We're going to see why that is in a few minutes. But again, you got to be careful with these cardiodepressants because of the fact that they can lower that ejection fraction. You impair that cardiac output, you're going to find that you're not going to be able to perfuse very well. That can actually be an acute, or cause an acute exacerbation for these patients. It'd be really obviously with diastolic dysfunction, a lot of this comes from impaired relaxation of the vessels there. And again, a lot of this changes occurs kind of insidiously over time. And so this is where things like our ACE inhibitors are going to help with this remodeling and help to try to preserve that function, help keep a nice kind of compliant ventricle that doesn't get too hypertrophied, is going to be kind of useful for longer in those cases there. Okay. And keep in mind with this compensatory response, so what's going to happen when the heart or the body is detecting that we're not really pumping enough blood here, cardiac output is suffering. Well, how does the body respond to that? RAS system is going to get activated, so renin-angiotensin-aldosterone system. So what does that do as far as like volume status? You're going to increase it, right? We're going to hold on to more salt, hold on to more water. What's the problem with patients with CHF and fluid anyway? They don't manage it very well, right? Again, so you're going to find that they get very edematous. They're going to be holding on to a lot of fluid here. That's going to be one of the big components, one of the big reasons why patients come into the hospital for an exacerbation is usually due to that fluid accumulation there. You're going to see that vasoconstriction, so your TPR is going to go up. You can see things like tachycardia associated with this to try to increase that contractility, increase that heart rate to try to get cardiac output up. And so because of that, just like any muscle, you overwork it, it's going to get bigger, it's going to get stiffer, it's going to actually get less functional over time, as you know. And again, this is a very cyclic sort of thing here, where again you're going to find that due to decreased cardiac output, you're going to find that this is going to decrease tissue perfusion. This leads to things like the renin-angiotensin system getting activated, more water retention, more congestion, more edema, and then all that feeds back into eventually causing worsened cardiac output, worsened heart failure. So again, we need to interrupt the system somewhere in order to try to prevent further progression of disease. And so it's one of the big ways we can interrupt the system. Yeah, it's where ACE inhibitors, where renin-angiotensin system antagonists are actually going to be playing a role here. So we're going to see that that's going to be kind of pivotal to making sure we can preserve this function as best we can. It's going to be something that's going to interrupt that renin-angiotensin system. Okay, so common reasons why patients will have a decompensation usually end up in the ER for CHF exacerbation. One, lack of compliance, right? Does that just mean with their medications? Could be lack of compliance with their diet, right? So again, if they go and binge, they say they go to an all-you-can-eat buffet, say they visit the Golden Corral, and they were to consume, say, an entire salt mine's worth of sodium in one sitting, which it can't happen. That could be something where they're not being really compliant with their DASH diet, right? It's not DASH back to the chocolate fountain at the Golden Corral. Not that I've been there recently or anything. Just kidding. I grew up in Palaca. That was like a staple of our diet. Anyway, things like uncontrolled hypertension, arrhythmias can actually exacerbate this. That can kind of acutely worsen ejection fraction there. And again, looking at things like, if they have inappropriate medications being added on that can worsen their symptoms, or if they have, say, fluid overload. How can you kind of detect fluid overload in these patients? What's a good way they can kind of monitor for it? Check their weights, check their weight every single day, right? That way they can kind of key in on that before they start to have kind of the overt sort of edematous conditions, right? So you want to be able to monitor for that, and that's why I say take daily weights for those patients. Other things, acute anginal chest pain, pulmonary infections, emotional stress, any of these can be other common precipitants you can see for this. So looking at non-pharmacologic therapy, because again, it's important to focus on this in addition to the meds. Obviously, you limit sodium intake. It's going to be one of the best things they can do for themselves is getting less sodium in. Means they're going to have less water is going to be held along with that, and try to limit fluid intake as well if possible. Okay, and again, physical activity, while it may actually acutely exacerbate some of their symptoms, it may help to improve functional status overall. Right, so if you can get them some kind of limited exercise regimen to try to increase that exercise capacity, that's always going to be good for them. So, but the drugs is what we're going to focus on here because this is obviously your pharm class. So, first thing first is your diuretics. Okay, diuretics are going to help us do what? Get rid of the water and also get rid of sodium, right? We're going to get rid of sodium, we're going to get rid of the water, and it's going to help to decrease that edema there. Now, do you think this is actually going to help with anything as far as mortality benefits go? This is the big thing we're going to focus on with CHF, is do these drugs provide symptom benefits or do they provide mortality benefits? Or can they do both? So looking at it from a diuretic standpoint, what do you think? Mainly going to be symptoms, right? They actually don't find much from a mortality standpoint by giving diuretics here. Now, most of the times, thiazide diuretics are not going to be useful enough by themselves. Now, when might you use a thiazide diuretic in a patient with CHF? For blood pressure control, right? We saw that thiazides typically are better for blood pressure control kind of chronically than you saw with our loop diuretics here. But typically, if you had someone who's coming in with an acute exacerbation, say they're 15 pounds up just from wet weight compared to what their baseline is, you're going to find that thiazides are going to be, like throwing a pebble at the problem here. We want to get something bigger. We want something more potent here. And that's where our loop diuretics are going to be playing a big role. Okay, so loop diuretics are going to be a big player here. What are the main loops we're going to use? Furosemide, bumetanide, torsemide. What's the fourth one? Ethacrynic acid. When do you use that? Yeah, if you're allergic to like furosemide or something, you can use ethacrynic acid as an alternative. Now, those are going to be really good. Now, imagine how you might prescribe that for a patient with CHF. Do you think it's something they're going to take it every single day? Possibly. It depends on the case, right? So it could be someone who maybe the more severe, the more kind of progressive they are, you may find that they tend to hold on to a lot of water. You may want them on a diuretic kind of chronically, right? You may want them to take it, say, twice a day, Lasix, every single day. How else might you want to prescribe that? Say you had someone who's maybe a little bit earlier on in the disease progression. It's not going to be scheduled. You could do it as PRN, right? It could be one of those things where you give them very explicit instructions. Hey, take this as needed if you notice, say, greater than so many pounds of weight gain in a day, or if you notice that you start to develop, some pitting edema or something like that, or anything like that, where you can kind of give them some direction on when they should start to take it, because that can help prevent an exacerbation, prevent them from being hospitalized if you can potentially get that fluid off before things kind of get out of hand. So that could be one of those things where you may see PRN recommendations. You may see it scheduled. Could be dependent on the patient there. Okay. But again, this helps with the symptomatic benefits of getting that fluid off very quickly. And again, monitoring that fluid weight is going to be the best thing to help us kind of detect that, especially if it's more than a pound per day for several days. Like they're just going to be holding on to that fluid there, right? Now again, not mandatory therapy. Not every CHF patient has to be on a diuretic. We're going to see some drugs that they need to be on. They really should be based on guidelines. But diuretics are not a absolute mandatory. They should be on this. Okay. Now, just one other thing with the diuretics. Remember that loop diuretics obviously are working where? In the loop of Henle, right? So again, what are some of the side effects you could see from using a loop diuretic? Hypokalemia, right? That's a big one, right? Because again, you're going to be losing a lot of that potassium. You need to be aware how these drugs are going to be affecting your potassium levels, because again, CHF could lead to what sort of issues? Arrhythmias. Again, you're on this remodeling of the heart, you're causing this kind of altered electrophysiology, can lead to arrhythmias, and electrolytes can play a huge role in exacerbating those arrhythmias. You got to watch either they're hypokalemic, hyperkalemic. You got to know how these drugs are affecting your potassium level. So a loop diuretic would cause hypokalemia. You got to watch for that. Make sure you're either supplementing or having on something else that's going to be bring that level back up. Okay. Now, are loops always going to be effective? Are they going to be? What if you had someone like really poor renal function? Remember, they still retain efficacy, right? You're going to find loop diuretics can still be used in patients with poor kidney function. They'll still retain efficacy. What could you not use potentially? Say if the creatinine clearance less than 30. Thiazides, except for metolazone. Remember, metolazone is when you can use less than 30. And what we'll see frequently, especially with patients, they'll develop what we call loop resistance. Did I talk about that before? Loop resistance is basically a phenomenon where the kidneys, again, they don't want to get rid of all that fluid, right? They're kind of used to having that around. And so one of the things you'll find is that when the loop is being affected, you're blocking that reuptake of sodium and chloride and potassium. What's the next portion of the nephron that could potentially pick up the slack? The distal convoluted tubule, right? So you're going to find the distal convoluted tubule is going to try to pick up the slack and absorb all that water and salt to try to compensate for that. So they become resistant to the loop diuretic. Well, how can I combat that? What's going to work in the distal convoluted tubule? Thiazide diuretics, right? So you'll see patients who are on loops, they become resistant. They'll add metolazone on, and that will help to increase that urine output quite drastically. So if you ever see that combination, that's why they're doing that. Okay, again, that might be something you see more on the inpatient side than anything else. Anywho, next up we have our ACE inhibitors. Now ACE inhibitors would do what to potassium? It would actually raise it up. Why would it do that? Is decreasing the activity of aldosterone. Remember that aldosterone, when active, is going to be causing sodium retention and potassium excretion. So if you interrupt that, you're going to cause potassium levels to go up. Good. Now these are going to be good because they help with decreasing the afterload. That's going to be the primary thing they're focusing on there. Maybe a little bit of preload. But the other big thing is they're interrupting this kind of cycle that's leading to progressive heart failure. So patients need to absolutely be on an ACE inhibitor if they can tolerate it from the standpoint. So decreasing that sympathetic activation, you're going to find that you help to reduce that hypertrophy, that remodeling, that dilation that occurs, and helps to slow down that progression. So by doing that, you're going to hopefully keep that heart healthier for longer and will decrease mortality overall. Now, who may not be a good candidate for an ACE inhibitor? Yeah. Okay. So if you had history of renal failure, what would be the concern there? Yeah, when you remember we said that ACE inhibitors can cause an acute decrease in GFR in patients that really require that Ang2 around to cause that squeeze on the efferent arteriole. Now, does that mean I cannot use ACE inhibitors in those patients? No, I got to start low and go slow, and that's the big thing with CHF you're going to find is you got to start low with these drugs and then gently titrate up. Otherwise, you're going to throw them into a decompensation. So you want to do that. So that would not be the case here. What if they had a history of angioedema? That'd probably make them a good candidate for not being on an ACE inhibitor. What could I use as an alternative? ARBs, right? So again, if a patient cannot be on an ACE inhibitor, say they have really bad chronic cough seen with it, history of angioedema, this is where ARBs are going to be preferred. Again, ARBs can still cause angioedema. Small risk, but again, some people are more comfortable with switching them over. You're going to titrate, watch them, see how they're going to respond to that. Okay. Anyway, so other benefits here, they're going to improve exercise tolerance, they're going to decrease heart failure symptoms, fewer hospital admissions, that's always going to be a good thing, and then prolonged survival. Okay, so again, increase the quality and the quantity of life for these patients, which is going to be good if you can get it from both sides there. Okay, as I mentioned, watch out for the renal function, again, hypotension, if they already have low blood pressure, that can exacerbate that, and then watch the potassium levels. Okay, so again, we kind of addressed all these issues already. Now, the other thing we want them to be on is going to be beta blockers, right? So beta blockers and heart failure, there's actually 3 that have an FDA-approved indication for heart failure currently. We have carvedilol, which fell into which beta blocker category? A 3rd generation, right? What was the extra benefit of using carvedilol? Yeah, a little bit of alpha blocking effect. So alpha-1 blocking causes vasodilation, so it can actually help with the blood pressure as well. So you get some additional benefit there. We also have metoprolol succinate. When you see succinate, you think the hard candies, right? Your Werther's Originals, maybe you got from your grandparents. The XL formulation, right? This is going to be the long-acting form. Now, again, if you saw someone on XL metoprolol twice a day, that's wrong, right? You need to be on which one-time daily metoprolol XL. And then bisoprolol as a beta is the other one you're going to see there, right? So any of the 3 of those would be good. They've shown mortality benefits for these patients here. Now, again, the thing you're going to find is that, again, with CHF, the heart's just kind of chronically being overworked. By giving a beta blocker, you kind of help to kind of relax it a little bit. You kind of take off some of that stress from the sympathetic nervous system. But again, remember, acutely, if I give too big of a dose, what happens? Their EF is going to go down, and that's going to cause an exacerbation, right? So you don't want to do that. So you have to start really low dose. Typically, patients are going to get started inpatient. They're going to get started in the hospital so that we can monitor for them. You can look at their weights. You can look at their vitals. You can look to see how they're responding to it, and then you gently titrate them up, and you get them on as most of the maximal doses they can tolerate. And what you end up finding is that typically in healthy patients, what do beta blockers do to exercise tolerance? It goes down. For these patients, it actually goes up pretty significantly if you can get them on a nice dose there. Okay, so again, this is going to help with that exercise tolerance as well. Okay, so typically over 6 to 8 weeks you're going to be titrating them up, and so that would be something you build into your prescription. Say, hey, start on this dose for this this many weeks. Week 3 bump it up to this. Unless you're doing it in the hospital, then obviously you control all that right there. And again, watch for those worsening signs and symptoms. Look for the weight. Look for the vitals. Look to see how those are changing. Okay, as I mentioned, increased exercise tolerance. You're going to find increased hemodynamic improvements, both from mostly from an afterload sort of standpoint there, and you're going to decrease that disease progression, right? So good from that standpoint. Again, typically their first line for patients who are going to be class 2 through 4 heart failure. Any of those patients are going to benefit from having a beta blocker on board, right? So again, these CHF patients at a minimum need to be on an ACE inhibitor and a beta blocker. Okay. Now, if they have diabetes, what should they be on? ACE inhibitor, right? So again, you already got some double duty there, right? They have a previous history of coronary disease. What should they be on? Should probably be on aspirin anyways, right? You're probably going to see, this is where you can see these med lists start to kind of spiral out of control. And you can have patients that are on a dozen or more medications, no problem. Again, that's why combination drugs can be so beneficial to them, right? How they increase that compliance. Okay, up next now we have a newer drug called digoxin. Does anyone know where you can find digoxin in nature? It's actually a very old drug. Not tree bark. Actually, what do you find in tree bark? The willow tree specifically. Aspirin actually comes from the willow tree, but digoxin actually comes from oleander. You can find oleander. There is lily of the valley, also a plant called foxglove that have very similar digoxin-like compounds in it. Now, oleander I mentioned, because where can you find oleander? Say you're driving on the 417 and you're looking at the medians, all the big bushy plants that have those nice pretty flowers on there. Those are actually super poisonous, so don't eat those. But those actually have a lot of digoxin-containing compounds in it. Actually, I was mentioning to my wife, she's really big into landscaping right now. I was like, let's just go ahead and let's get some of those oleanders in there. She's like, I'm not going to put poison in our backyard. I was like, it's like, Darwinism for our kids, like natural selection. Let's see how they do. Just kidding, I would not recommend that. So anyway, so this is digoxin. So it's a very old drug. We've used for CHF for a long time. Back even when CHF was called dropsy, back in the day, we would give kind of concoctions containing these digoxin. Basically what this does, it actually inhibits the sodium-potassium ATPase pump. Okay, so its mechanism very specifically is going to interrupt this pump right here. Okay, so again, what does the sodium-potassium pump normally do for us? Kind of resets the resting membrane potential for the heart, right? So it's going to help to reset that membrane potential. So imagine if you stopped this pump from working, what happens to sodium levels within the cell? they would go up, right? Because again, normally, remember, this is pumping against the concentration gradient. That's why it has ATP it needs. So it's going to be using sodium, pumping it out of the cell, using the pump to get potassium into the cell. If I inhibit this, right, so if I were to stop this from working, what happens to sodium levels within the cell? They're going to go up, right? Because the pump's not working. So sodium levels are going to go up in this case. And so what you end up finding is that there's increased activity of this sodium-calcium antiporter. Antiporter just means going in opposite directions, right? So because I have more sodium here, that means this pump is going to have to work extra hard to get rid of that sodium, which means that for sodium to go out, it has to bring calcium in. Okay? What is calcium used for in the heart? For contraction, right? So, and again, what were we saying the issue is with these CHF patients? Contractility is a problem, right? So again, they can't get their EF up because maybe the vessels or the ventricles have gotten more fibrous and they're just not really responding, with they're too hypertrophied. This is one of those things where by increasing the calcium levels here, you kind of increase the ability for the sarcoplasmic reticulum to release calcium. As we're going to see more actions of the actin and myosin coming together, you get better contractility. That's what we were using it for a good long time. But we saw that digoxin helps to increase contractility. It helped to deal with get the EF up and help to improve symptoms for these patients. Okay. That's how we use it for a good long time. And so we consider this to be an inotropic agent. Inotropy just means what? A contractility, right? So I have a negative inotrope. What's an example of a negative inotrope? Beta blocker, right? Non-dihydropyridine calcium channel blocker. Positive inotropes are going to be things that help to increase that contractility, and digoxin is the first one here that we have that actually does that. So it's going to be increasing that force of contraction there. So positive inotrope. Now, if I said it's a negative chronotrope, that just means what? Yeah, decreased heart rate. In this case, this is not the case here. You find that digoxin has no effect on chronotropy, at least at therapeutic levels. We'll find that it can be a little different as we go on. But anyway, that's kind of the older mechanism. We thought that's how it worked for a good long time. Nowadays, we realize there's kind of some alternative mechanisms that's going to be working through. We call this the neurohormonal pathway. And so basically what it's going to do is help to increase parasympathetic activity on the heart and decrease sympathetic activity. That's good. That kind of helps to interrupt that system there, because again, you have less norepi being put on the heart. You have more, acetylcholine. That sounds like a good thing. It helps to resensitize the baroreflex. What is the baroreflex used for? Detects changes in pressure there. Remember what we said with chronically hypertensive patients? What happens to those baroreceptors? They reset themselves. They say, hey, this is the new normal. We now live at, say, 160 over 100, right? But if you end up having a resensitization, that's where you can start to drop that back down and say, okay, now this is a normal pressure here, right? And this is going to help to decrease activity of the renin-angiotensin system. So again, there's a lot of benefits to see with this. And again, we can actually shoot for lower doses, which is a good thing, because I can actually find this drug is actually pretty toxic. So again, just some of the neurohormonal actions. Again, if you want to get more in detail on some of this thing you're going to find with this, is that by working the baroreceptor, by inhibiting that sodium potassium pump, it's going to lead to decrease in heart rate. It's going to help with decreasing blood pressure, heart rate. So again, all good things, all things that help kind of increase the cardiac output here. So better, more efficient sort of pumping. Now, looking at this again, we shoot for certain target levels. This is actually a drug that has a very narrow therapeutic index, which means we have to do what? To monitor for blood levels here, right? And again, I'm not going to have you memorize the level here. I'll put that if I have a test question, I'll put a patient comes in with a level of this, and I'll put the reference ranges. But just note here that again, the units absolutely matter here, because again, notice here this is in nanograms per ml. You don't need a lot of digoxin to get its actions to be seen, because again, a lot of drugs get represented in micrograms per ml, milligrams per liter. So watch your units, because if something gets expressed in a different unit than you're used to, it can lead you to some erroneous conclusions there. Did I ever tell you the aspirin overdose that I had? Where the units were told incorrectly? Basically, usually aspirin is in milligrams per deciliter. Normally a level of 100 can be fatal. And I called a hospital and they reported back, oh, the aspirin level is 500. I go, oh no, 500, that patient must be dead already. And they're like, no, he's fine. He's just sitting there, just kind of breathing a little fast. I said, hold on, what are the units? And they said, oh, this is micrograms per ml. So okay, so I did some quick conversions. Not my head, I had to write it down. I was like, oh, it's actually just 50 milligrams per deciliter. That's much safer than a 500 level in milligrams per deciliter. So watch your units. You always got to be careful with that. Okay. Anyway, so what we're going to find is that we're shooting for a little bit lower levels here, 0.5 to 1 nanograms per ml. So you're doing that therapeutic drug monitoring. You're monitoring those levels to within that range there. And what we see is you get some benefits in their symptomatology. You're going to get some increases in exercise tolerance, and quality of life goes up. However, there's no survival benefit here. So a patient with CHF does not have to be on digoxin. A lot of them are not going to be on digoxin because the monitoring and the side effects tend to get in the way here. Okay, but again, no survival benefit. It's almost like all in caps, like I wanted to provide some extra insight into this. Anyway, so again, no evidence that it slows down disease progression like you would see like a beta blocker or an ACE inhibitor here, but it could be useful if patients are kind of optimized on ACE inhibitors and beta blockers. If you need something additionally, this is where digoxin can play a role here. Okay, you'll oftentimes see digoxin being used for AFib as well. It can help to control those symptoms there. So you may see that occasionally, especially, and again, if CHF was kind of preempted by things like AFib, that can be one of those things where you can see that digoxin kind of pulls double duty there. So the toxicity is the thing to know here. You see a lot of GI toxicity associated with this, a lot of nausea, vomiting. But the interesting thing is, and this is the things you want the patients to be warned about, because that way they can actually notice whether or not they're getting toxic right before they have a level done. And so this is where you see a lot of visual disturbances. This is kind of the first thing that I think about when I think digoxin toxicity. Very, very typical of this. So you can see things like blurred vision. You can see things like photophobia. But kind of the more interesting things are they actually have what we call xanthopsia. Anyone know what that means? The XAN prefix usually means what color? Yellow, yeah. So xanthopsia means you have a yellowing of the vision. So everything kind of has like kind of a yellow hue to it. Maybe that's what inspired Coldplay. I have no idea. You also get these kind of halos that will form around lights and things like that, and kind of yellow greenish sort of halos that can form there. And I will tell you, I remember when I was like my first year of pharmacy school, I'll never forget this. I was in Jacksonville and I was at the Y at the time, and at the Y, some of the patrons there tend to be a little bit more on the geriatric side, and so they like to hang around, just kind of shoot the breeze with their buddies and just kind of socialize. And I will never forget this guy was talking about. He's like, oh yeah, I'm on all these heart medications, and boy, I tell you what, it had weird halos around all these lights and things like that. And I thought it was the weirdest thing I'd ever heard because I was just kind of eavesdropping inappropriately. But later on, once I actually learned about digoxin, I was like, oh no, his level is probably too high. I hope he survived, but I'll never know at this point. Likely not at this point. That was a lot of years ago. But other things you can see, when the levels are too high, it could be things like CNS confusion, you can have delirium, fatigue. So again, when you have these elderly patients, again, watch out. Is it just their delirium is worsening? Is it just their Alzheimer's kicking in? Or is it because of the medications that they're on? So again, all these would be indications you may want to check a level, kind of see where they're at. Now, the other big toxicity you're worried about with digoxin is going to be the cardiac aspects of this, okay? So again, one of the things you'll learn with digoxin toxicity is that any arrhythmia is possible. You can see tachyarrhythmias, you can see bradyarrhythmias. With certain things like, say verapamil, what kind of arrhythmias would you expect? Bradyarrhythmias, right? Bradycardia, AV block, all those things you expect based on the mechanism of the drug. Here, this is going to be different because we're affecting that resting membrane potential, right? We're affecting that sodium-potassium pump. So you can see kind of all kinds of things, tachyarrhythmias, bradyarrhythmias, and in fact, there are actually some very typical sort of digoxin sort of EKG findings you can actually find there. And so in these cases, bradycardia is probably the most common thing you're going to find, but what you also find very commonly, especially when levels are getting a little too high, are going to be these induced after depolarizations, right? So basically you have say a normal sinus rhythm, and then you have kind of a premature ventricular beat. Okay, so it's a very common thing that shows you that the myocardium is kind of aggravated and that it's having these kind of premature beats a little too soon. Now, is that going to be detrimental to the patient in and of itself? Not necessarily, but it kind of shows you that things are not in the right direction, right? You need to check levels. You need to make sure you check their electrolytes, because that's also going to be playing a big role here, right? Potassium is super, super important to watch for when you have a patient on digoxin, because it can worsen these arrhythmias here. Now, looking at the mechanism, we saw that we're inhibiting that sodium-potassium pump. What do you think happens to potassium levels when you're on digoxin? You think it would increase or decrease? Because I'm inhibiting the pump, which the pump is normally bringing potassium into the cell. So that means all the potassium is left on the outside of the cell. You see potassium levels go up in these cases, right? So this is another case where you see a transient increase in potassium levels due to the fact that you're inhibiting that pump there. Now, does that mean that total body burden, they have increased potassium levels? No, it's all the same. It's just been shifted around. And that's one of the big things you'll find when we talk about treatment of hyperkalemia, is you just want to shift it to the right places within the cells or outside of the cells. So in this case here, you're going to find hyperkalemia as a potential side effect here, right? Which can worsen the arrhythmias. So contraindications here, if you have already advanced AV block or severe bradycardia, you do not want to administer digoxin because that can just worsen that. Any history of ventricular tachycardia, PVCs, again, that can be aggravated by digoxin. If they are already hyperkalemic, this is just going to worsen that. It's going to drive their potassium levels up higher. If they're hypercalcemic or hypomagnesemia, they also tend to see worsened risk for arrhythmias as well. So watch out for that. And then Wolff Parkinson White is another contraindication. Just due to anything with the accessory pathways like that, you don't want to have a negative, chronotrope there that can kind of worsen that accessory pathway. So one thing to avoid with that. Okay, so again, I always like to talk about reversal agents because that's kind of my thing. But how do I reverse digoxin? Well, there's actually an immune globulin we can actually administer. And so this is actually a digoxin immune fab. And what's kind of interesting with this is that normally when you think about antibodies, you normally think about kind of the Y sort of shape here, right? And again, this is kind of a poor representation, right? So which portion is the FAB? Yeah, it's kind of the arms here, right? The FAB is going to be the arms. It's actually going to bind up with the whatever's targeted against. But again, when I mentioned giving foreign proteins, what's a risk? Yeah, hypersensitivity, anaphylaxis. This is actually from an ovine source. Anyone know what ovine means? Which animal? From sheep, actually. So sheep are actually the source where we actually got this from. We'd hyperimmunize sheep against digoxin, and then we take those antibodies. What's kind of cool is instead of, and again, I don't know too many sheep human hybrids out there, but they, people could have a potential reaction. So what we do is we actually cut off part of the FC portion, and by shortening up that antibody, it makes them much less likely to actually have cross-reactivity. So I've actually never seen anyone have an anaphylaxis to one of these ovine-derived antibodies here. But anyway, it's kind of interesting because if you had someone who has having acute digoxin toxicity and it's manifesting especially as like severe bradycardia, hypotension, arrhythmias, this is what we end up giving. So it's an antibody that will go and bind up that digoxin and then allow the body to kind of eliminate on its own. Okay. The other big thing to watch out for with digoxin is renally eliminated. You have to watch renal function. And again, renal patients, what kind of electrolyte disturbances can they have? Hyperkalemia, they have issues with their magnesium, issues with calcium. So again, you can already see you gotta be careful with renal patients because their electrolytes are going to be all over the place, and that can worsen this digoxin toxicity. So you gotta watch out for that as well. Okay. All right. So moving on, next we have our aldosterone antagonists, and so we have the two main ones we're going to use here are going to be spironolactone and then eplerenone. What's the big benefit of using eplerenone or Inspira? No gynecomastia. That's a big benefit there, right? So again, the concern with spironolactones is going to cause gynecomastia. Why does it do that in male patients? Remember, it's a partial androgenic receptor agonist, right? That means it's only going to partially agonize testosterone receptors, which means for male patients, it's going to lower their testosterone activity overall. For female patients, what will that do? Increase activity, right? So again, remember those, you can see masculinizing effects in females, you can see feminizing, what's the word I'm thinking of? Female sort of development in male patients. Again, my words are escaping me now. We're going an hour 2 and 3.5 hours of sleep. Just reiterate that. Anyway, but by having an aldosterone antagonist, what do you think that does to potassium levels? It's going to increase it, right? So again, you got to be careful. They already have existing hyperkalemia. You cannot administer these drugs here. Also, the other thing is that their serum creatinine is already above a certain level, usually 2.5. You're going to find you do not want to administer it as well, because again, those patients tend to have hyperkalemia associated with that, okay, or they tend to be more at risk for developing that, okay. And again, we don't know the full mechanism necessarily, but we think it somewhat has to do with that neural hormonal inhibition, kind of helping with slowing that remodeling there of the left ventricle. Again, this is slowed progression, which means you're going to have increases or improvements in mortality when you're administering this. And so what we actually do is we'll administer if you have grade 3 or 4 heart failure, give them spironolactone, they should see some mortality benefits from that. Okay. So again, in that case we had a couple weeks ago, when you had a CHF patient, they were already getting into stage 3. They would probably be a good candidate for for getting something like spironolactone, in addition to an ACE inhibitor, in addition to a beta blocker, in addition to whatever else they needed, right? Okay, so some other agents you may see on for a CHF patient could be if they're coming in for an acute exacerbation. Oftentimes what we want to do is give them a positive inotrope. We want to give them something kind of help kick the heart a little bit and give them a little bit better contractility. So these are a couple of IV agents we're actually going to be administering that can help to do that, right? And so we have milrinone and we have enamrinone. All right, so those are the two main ones. These are actually phosphodiesterase inhibitors. And where did I mention phosphodiesterase inhibitors previously? with the erectile dysfunction medications, but keep in mind that was PDE5. This is actually PDE3. PDE3 is going to be more specific to the heart, and it's going to help to increase contractility. It's going to help by decreasing the actual breakdown of cyclic AMP. More cyclic AMP within the heart is going to cause an increase in contractility there, so if I can inhibit that breakdown, that's going to be beneficial, okay? So the nice thing here is they're inotropic, plus they're also acting as a vasodilator, so it's going to cause some smooth muscle relaxation as well. It can be good if you have a patient coming in for an acute decompensation, and they're also very hypertensive. I can give them milrinone, get the cardiac output up, and also kind of get the blood pressure down a little bit in those cases. Those can be a nice benefit there. So again, decreasing the afterload and increasing that cardiac output. And typically we use these for as IV infusion, so again, it's IV only. We actually find that if you put patients on this for a long period of time, you actually find an increase in arrhythmias and death, so we don't like that, but it's good for an acute decompensation to kind of get them kind of back on their feet. You're going to get them on one of these, you're going to get them on some Lasix to get rid of that fluid, kind of get them back to baseline, and then you should be good to go. You can take them off these inotropic agents at that point. Right. Again, biggest risk though is going to be ventricular arrhythmias. Anytime you're kind of increasing inotropy or chronotropy on the heart, you're going to find that arrhythmias are always going to be a risk there. Okay. Another one you may see occasionally is called dobutamine. This is actually going to be specifically a beta-1 agonist. So again, it doesn't really affect beta-2 at all. It's going to be a beta-1 agonist here, and so you can give this as an IV infusion to increase. Just like you would see with an increased sympathetic nervous system effect, you're going to find an increase in contractility, increase in heart rate, and that can help to increase that cardiac output until you kind of get the patient stabilized. That's one drug you might use, and another one is called dopamine. Again, dopamine we know about, our brains produce that all the time. We can actually give this as an IV infusion as well. And this will help to increase cardiac output. This one actually acts as a vasopressor though. When I say vasopressor, anyone know what that means? Increases blood pressure. So, say for instance, I had a patient who came in, and I said, oh, they came in, they're bradycardic, EF looks pretty puny, but they're hypertensive. Maybe something like milrinone would be a good option for them because it's going to help as a vasodilator. But if I say they're coming in, they're bradycardic, and they are hypotensive, something like dopamine is a really good option because it's going to increase cardiac output and also act as a vasoconstrictor to get that blood pressure up. We'll talk more about vasoconstrictors in a different case here. We have a whole host of them, but this is one you're going to specifically see used a lot for CHF decompensations. Okay. Any questions on that? If not, let's move into part 4. All right, so this is the last section for cardio. Yay! Anyone? No one? No one? Okay, that's all right. So talk about focus. We're going to see with this. So big principles with antiarrhythmics is one, we'd like to fix the original problem for the arrhythmia. So for instance, if someone overdoses on a drug and causes an arrhythmia, what would I like to do? Probably get rid of that drug. Maybe I can dialyze the patient and get rid of it. Maybe I can give them an antidote or something to get rid of it. If they're hypoxic, what should I do? Perhaps give them some oxygen, right? So these are all things you can kind of try to fix. If their electrolytes are off, try to correct the electrolytes. Either get rid of stuff that's in excess or give them supplementation of things that are low. That's great. However, you're going to find that just due to some patients either having sort of congenital issues, sometimes you can find that ischemia can precipitate a lot of this. You're going to want to administer medications that can either help to eliminate a currently active arrhythmia or to try to prevent an arrhythmia from developing in the future here. Okay, and so what you're going to find is that you have to be really careful with the antiarrhythmics. Any one of these can cause an arrhythmia, right? So again, let's be really careful because we're going to find that we're mainly going to be monkeying with electrolytes and these transporters here within the cardiac cells. So again, if you have to, go back and review your physiology stuff as far as, where calcium's coming in, where sodium's coming in, all that good stuff, because it's going to help us to understand what these drugs are doing and how they're going to be affecting the heart rate, how they're affecting the EKG, etc. Okay? And again, you have to consider electrophysiology of the heart really as a moving target. So again, looking at things like how ischemia develops and how that can modify how some of these arrhythmias may develop, how you get different range of arrhythmias that can occur depending on things like, changes in intracellular calcium or changes in conduction velocity. Because again, normally functioning healthy heart is going to be allowing to work as that functional syncytium. Remember that term we talked about? It was all working nice in concert. But if you were to cause part of the heart to become ischemic and maybe not conduct as well, that can interrupt that whole thing, and that's where you can find arrhythmias develop. So how we classify our antiarrhythmic drugs, this is going to be called the Vaughan Williams classification, and it's going to be based on the mechanism of action of the drug. We're going to find it either due to things like sodium channel blockade. We can do things like try to prolong the action potential, We can do things like blocking beta receptors, or we can do things like block calcium channels. Okay, so then there's going to be some miscellaneous agents, but these are the main targets we're going to be focusing on as we get into the specific drugs here. So anyway, here's the classification. Class 1 is going to be our sodium channel blockers. Now within class 1, there's going to be several subclasses. There's class 1A, 1B, and 1C. And have you covered these yet in cardio and CMS? A little bit. Okay, so we'll get into more detail on these, but basically the sodium channel blockers are going to be class 1. And then you have 1B, 1A, 1B, and 1C, and they're going to have a little bit different activity based on how they're interacting with these sodium channels. Okay, we'll talk about these in detail in a second here. Class 2 are your beta receptor antagonists. What drugs are those? Beta blockers. Yeah, we already talked about beta blockers. We know all about those. So that should be a quick review. We're going to have drugs that prolong repolarization. There's going to be mainly affecting potassium efflux. There's going to be some new drugs we'll talk about there. And then we have our calcium channel blockers. Now, which calcium channel blockers am I talking about? Dihydropyridines or non-dihydropyridines? Non-DHP, namely verapamil, diltiazem. Those are the two main ones you're going to see used here. Now, dihydropyridines like amlodipine would not fit into this categorization here. Those are not considered antiarrhythmics. Okay, they can cause tachycardia, but they're not going to be treating a tachycardia. And we'll have some additional agents, some miscellaneous ones, things like adenosine, digitalis. We'll talk about those in a little bit later. So looking at the indications, and don't spend too much time kind of memorizing this entire slide, but the things I want to kind of focus on are what type of arrhythmias can you treat with these different classifications of drugs, and it'll make sense based on the type of mechanism that the drug's going to be having here, right? So for instance, you think about like, a beta blocker, or say like a non-dihydropyridine calcium channel blocker. What's the main effect you're seeing with that in terms of something like an arrhythmia? It slows down the heart, right? So again, do you think it's going to be better for treating, say, a supraventricular arrhythmia, say, originating in the atria, or something that's going to be in the ventricles? It's going to be better to treat something in the atria, right? Because again, when you have a supraventricular arrhythmia, the signal starting in the atria being transmitted down to the ventricles, and that's what's causing the arrhythmia, right? If I can block that, if I can slow down that transmission by affecting things like the SA node and the AV node, that can interrupt that transmission and interrupt the arrhythmia. Okay, so typically for your non-dihydropyridine calcium channel blockers and your beta blockers, those are going to be good for supraventricular arrhythmias. Okay, class 1 and class 3 that are affecting sodium channels and affecting potassium channels, those are going to be good for either. So you can use those for ventricular originating arrhythmias, or you can use them for atrial arrhythmias. So keep that in mind, because I say a patient comes in and they're in VFib, the choice of drug is going to be very different. You would not select a beta blocker. You would not select a calcium channel blocker, because that's just going to exacerbate it. You're just going to cause that normal rhythm coming from the SA and the AV node to not actually be to come through, and it is not going to be able to help to establish that rhythm. Okay, so again, keep in mind what these are going to be treating. And this will kind of bear out when you're looking at what different arrhythmias you can actually use these for. Okay, so you don't memorize the specifics here, but just kind of get the broad generalization that the 2 and 4, the calcium channel beta blockers and calcium channel blockers, are good for supraventricular arrhythmias. 1 and 3 are going to be good for either atrial or ventricular arrhythmias. Okay. All right, so let's look at the sodium channel. Now, where's the sodium channel going to be really important for function? In the pacemaker cells, or say those fast response cells? Fast response cells, right? Because again, what causes phase 0 of the action potential there? Sodium influx. So if I can block sodium influx, I can slow down that phase 0 and hopefully try to interrupt any sort of arrhythmias that are happening here. Because remember, when you have things like ischemia, it's affecting things like the refractory period. So remember, you have kind of 2 varieties of refractory period. What are those? Absolute and relative. Absolute means what? No signal can come along and introduce a new action potential, right, in that cell. The relative, though, can't, right? So if you have strong enough signals, that's what we're talking about here. When you have things like ischemia, you can alter that relative refractory period to make it more likely to have one of these reentrant arrhythmias happen, or one of these reentrant signals. So by altering things like sodium channel influx, or by affecting things like potassium channel efflux, you're going to find that you can modify this and try to change that refractory period to maybe make it more resistant to having one of these arrhythmias develop here, okay? What you're going to find is with the sodium channels, you kind of have 3 different states here. We kind of have the active resting state, where sodium just kind of bounces off. You're going to have the activated state, where this is when the action potential gets the signal is transmitted from the SA or the AV node and says, hey, all right, time to have an action potential. It's going to open up these sodium channels, and that's what causes that phase 0. And then you're going to have an inactivated state, where basically have this kind of other piece of the protein come in and block any further sodium influx. Okay. Now, based on which state it affects the sodium channel, you're going to find this is going to be delineating whether it's a 1A, 1B, 1C. Okay, those are kind of the main differences you're going to see with that. And so typically what you find is that the total degree of depolarization that occurs here is lesser, because if I'm blocking sodium channels, less sodium comes in, less positive, I can get that potential there. And you're going to see that kind of slows down the whole thing, right? You're going to find that the refractory period is going to be extended here because we're blocking that sodium channel influx. Kind of make sense? So the dotted line would be the drug effect. The solid line would be what would be normally would be happening with a typical myocardial cell, right? With those fast response cells. So what we're seeing with 1A, you're going to find that these actually have a more affinity for the open channel versus the inactivated form. So once phase 0 occurs, once those channels open up, that's when these drugs are going to kick in. It's going to bind to that receptor or that channel and then hopefully prevent any more sodium to come in. So it'll slow down phase 0. It's going to slow down conduction, right? That's why it's good from slowing down conduction from the atria to the ventricles, so that can help with those type of arrhythmias there. And it's going to have a pretty slow dissociation, which is why when you see that, you find it's going to help to prolong that whole action potential overall. Okay. What causes this plateau right here? Do you remember? Calcium influx. Remember that's what causes that prolonged plateau effect. And what causes the repolarization? Potassium efflux, right? So again, you got to know these as far as what phases, which electrolyte shifts are causing which phase, because it's critical for understanding how these drugs are going to be working. Okay. So the thing I used to remember, my class 1A antiarrhythmics is PDQ. Pretty darn quick. So we're going to have 3 drugs here. The first one is going to be quinidine. And this is actually an isomer of quinine. Anyone know what quinine used to be used for? Malaria. It's an anti-malarial drug. Anyone know where you find quinine in, say, for instance, you go out to the bar? Tonic water, absolutely. So that's why, and actually it glows in under black light. So if you ever get a gin and tonic, not that I would promote drinking while in PA school because you need all your brain cells while you're here. But if you were to take it under a black light, you'll actually see that it glows. And it's due to the tonic water actually has small amounts of quinine in it. So again, maybe drinking can help you prevent malaria. I don't know. I haven't done the study yet. Maybe one of you guys can do it. Already started, right? It's almost 10 o'clock. It's a little too early for that, right? At least wait till 10:30. Anyway, so quinidine is going to be the first one here. It fits into this category. So it's, again, all those same things we talked about. It's going to have affinity for that open sodium channel. So it's going to slow down phase 0, slow down that conduction there, and decreases automaticity, which is why you can see it's good for both ventricular and potentially atrial arrhythmias as well. Okay. Some other activities you can find is they can actually cause some anticholinergic effects. And remember the mnemonic we use for that? Mad as a hatter, blind as a bat, dry as a bone, right? So you can go through all those. Remember, those are some of the actions you're going to find, some of the side effects you can see with this drug. Now, what effects did anticholinergic have on the heart? If I decrease the effect of acetylcholine on muscarinic receptors in the heart, I'd expect heart rate to go up, right? So again, sometimes these actions can be kind of at odds. This is actually a pretty old drug, but again, you can sometimes see some of these bleed over effects. We'll see this with the side effects in just a minute here. Other big things here is it can cause alpha blockade effects. So what effects would you expect to see with that? Vasodilation, you expect to see some degree of hypotension that can develop with this. So again, these are things you want to be monitoring for if you had a patient who's on quinidine. So again, this is good for helping to maintain rhythm with things like A-flutter or AFib. And again, one of the things you'll see when we're talking about A-flutter and AFib is there's going to be a concept of rhythm control. There's a concept of rate control. Rate control just means you're just controlling the signal getting from the atria to the ventricles. So even though the atria may still be sending a lot of signals, so maybe kind of quivering there, you're going to find the ventricles are only getting kind of a normal sort of signal there. That's rate control because you're controlling the rate of the heart. Rhythm control is where we would give a drug to actually try to interrupt that atrial arrhythmia and try to reestablish normal electrophysiologic actions. Okay, so in this case, this would be something that would be rhythm control because it would be interrupting that arrhythmia there. Okay, so again, good for atrial flutter or fibrillation, good for ventricular tachycardias. In some cases, you may actually use it to help for conversion. Right. So what do you call it when you try to convert someone from an arrhythmia back into normal rhythm? Cardioversion, right? So again, there's electrical cardioversion you can do, and there's chemical cardioversion. This may be a case where this would be considered a chemical cardioversion, where you interrupt that arrhythmia, try to get them back into normal sinus. Okay. Other things to note here, it's actually a CYP2D6 inhibitor, which can be problematic if you had other medications on board, something like morphine. This is metabolized by that. You could actually see increased levels of the morphine if I'm prolonged effects. You can see some side effects associated with that, so watch out.
Why were we having the vasodilatory?
The alpha blockade. The high doses, you can say alpha blockade. Yeah. Now, some other things you can see, a lot of nausea, vomiting, diarrhea associated with this. And as I mentioned, you can find arrhythmias that can develop, just like any antiarrhythmic can cause arrhythmias here. Hypotension, which we talked about. And then, again, another reason why we don't use this too frequently, unless we have patients who are kind of refractory to other drugs, you can see things like a fatal thrombocytopenia. It's rare, but can be very problematic when it occurs. And one of kind of the unique kind of constellation of symptoms or adverse effects you can see with quinidine is what we call synchronism. Synchronism just has to do with it actually comes from a tree originally, the cinchona tree, but you can see this as well with quinine if you're treating malaria with it. But basically it's going to include this tinnitus, dizziness, and blurred vision. Okay, blurred vision, dizziness, that kind of makes sense based off things like the alpha blockade, the anticholinergic activity, but the tinnitus can be a sign that, hey, maybe levels are getting a little too high here, maybe we should probably switch this patient off of this drug. And then also this, you may want to be careful when you tell patients about a drug that can have a quinidine sudden death effect, right? You wouldn't want to tell patients. But again, it goes back to those ventricular arrhythmias. Because it can cause arrhythmias, a ventricular arrhythmia can oftentimes kind of look like a sudden death sort of thing, that syncope that occurs with that. So again, that's what that's referring to. And then anytime you're kind of prolonging the repolarization phase, as we saw with this one, you can see torsades is going to be a big risk here, right? Because again, torsades is going to be manifested by which finding on the EKG. I guess which interval you're looking at. Yeah, QTC, right? So when you see a prolonged QTC, that's when you know you're at risk for torsades, because again, you're kind of extending that repolarization phase in the ventricles there. Okay. Drug, but still you see it used somewhat sparingly. The P for the PDQ is going to be procainamide. This is actually a derivative of procaine, so very similar to some local anesthetics like lidocaine or bupivacaine. This one, actually, we have a couple patients who are actually on this in our cardiac center over at Nemours. This is good because it actually limits a lot of the side effects you saw with quinidine, so a little bit less anticholinergic activity, less alpha blocking activity there. But one of the nice things with procainamide, it actually has this active metabolite that actually has some class 3 actions. We'll talk about class 3 a little bit later on. But the thing to note with this is that this is actually similar to hydralazine in the fact this is metabolized through acetylation. Do you remember what happened to slow acetylators of hydralazine? That lupus-like rash, right? They have more pronounced drug effects, so the drug is sticking around for longer. This is actually another one we here, right? So again, slow acetylators, you're going to see that lupus-like rash that can form here due to that slow acetylation. Again, you can see some hypotension, slowing conduction. All these things are going to be pretty ubiquitous amongst the 1A sort of antiarrhythmics here. Again, torsades is a risk. And then again, not used frequently from an oral standpoint, but certainly IV. Like I mentioned, we have a lot of kids who are undergoing, open heart surgeries and things like that. Sometimes they'll get put on procainamide to try to suppress some of these arrhythmias from developing. And then the D here was disopyramide. Very similar actions to quinidine, very similar activities used for the same clinical indications. Any of the 1As can be used for atrial or ventricular arrhythmias. No problem with that. Again, very similar side effects here: antimuscarinic activity, hypotension. Again, this one can be a negative inotrope. So if you had a CHF patient, it can decrease contractility. That can be problematic for them. And obviously, risk for things like torsades. Yeah. So those are the 1As. I don't have too many minutes left here. I have 1 minute left. I'm actually going to cut it here. But so that was the 1As. So kind of keep those in your mind. We'll come back. Next time we'll attack the rest of the class 1s and then go through all the other ones and then move into Pulm after that. Any questions I can answer for you for a break? All right, come back and then just like Bon Jovi said, whoa, we're halfway there.